So we looked into aortic stenosis and the best predictor of outcome after aortic valve replacement in a large cohort of patients with aortic stenosis. Now, aortic stenosis is the most common heart disease after atherosclerosis and hypertension, and affects about 3% of those over 75. Now, when the valve gets narrower, the ventricle responds to preserve the wall stress and cardiac performance, but eventually it gives up. And this heart failure, which drives symptoms and morbidity, can be reversed by a valve replacement, surgical valve replacement, or TAVI. But there's residual risk after a valve replacement, and we try to find out what are the causes and what are the independent causes of this. Previous studies have suggested that scar is a main driver of the decompensation from hypertrophy to a heart failure phenotype, but I think with the studies so far have been too small to show the independent association of scar with outcome, total or cardiovascular mortality. So we set up a multi-center consortium in the UK, 6 UK centres, and looked at the predictive value of markers of ventricular decompensation, the size, the hypertrophy and the scarring of the left ventricle, and to see how that is associated independently with outcome in aortic stenosis after intervention. This was a prospective longitudinal outcome study of patients with aortic stenosis listed for aortic valve replacement at 6 UK centres. Now, patients had been listed for a valve replacement after being reviewed by the heart team. So they would either go for transcatheter valve replacement or surgical valve replacement. And we then performed echocardiography and cardiovascular magnetic resonance imaging. The echo was as per UK guidelines or European guidelines to assess valve severity, and the cardiac MRI was for the structure, function, hypertrophy and scarring in the ventricle. So we used late gadolinium enhancement, which highlights focal scar, and for all of those cardiac MRI parameters, we centrally assessed everything in a core lab approach. The advantage in the UK is that through the National Health Service infrastructure, we're able to get outcomes on 100% of patients. And then we're able to obtain death certificates to see what the etiology is. So the key findings, we included 703 patients across the 6 centres, very characteristic of aortic stenosis throughout, mean age 73, 63% male, lots of comorbidities, hypertension, AF, and diabetes. But then, and the severity of the aortic stenosis was significant, with a mean gradient of 49 millimeters of mercury and aortic valve area of 0.38 indexed. Now, looking at the ventricular parameters, we found that although the left ventricular function was preserved in the overall cohort at 58%, 51% of patients had scar. Now, this was 2/3 non-ischemic scar, which is patchy late gadolinium enhancement, and 1/3 out of the 51%, i.e. 17%, had infarct late scar, late enhancement. Now, we then looked at mortality, and those patients with scar were twice as likely to die of all-cause mortality and 2.5 times of cardiovascular mortality. And with every single % of extra scar, mortality risk actually increased by 10%. When we looked at the univariate predictors across the board, we had 52 parameters and 28 predicted outcome across demographics, valve severity, cardiac MRI. But when we used each parameter, the most predicted parameter from each domain, only 3 actually predicted outcome independently. And they were age, gender, and the presence of late gadolinium enhancement. So, and putting that all together in this really large study, multi-center, multimodality with echo and CMR, it shows that late limb enhancement is really a key predictor of outcome in severe aortic stenosis after valve replacement. Yeah, so I think SCAR is really key, and we need to determine it, and we need to find out in a clinical trial setting whether the timing of surgery should be brought forward in those who do have SCAR to prevent further SCAR progression, as you said, and prevent the residual risk after surgery of heart failure, arrhythmia, and death. Now, one of these studies is currently underway. It's the Evolved AS study in Edinburgh, which will be a multi-center study looking at the effect of using late gadolinium enhancement to guide surgery in those who are asymptomatic with severe AS.